and Art is a collaboration between Treatment Action Campaign and HIV Base, working together with AfroCap, and the project is funded by UnitAid. And much of our work actually includes translating this into this. Our goal is to educate communities to engage with the science of HIV and associated diseases so that people living with HIV can get the best possible outcomes from their treatment. And we also do a lot of contribution towards research and policy.
Thank you very much for bringing WHO into this brief movie, and I'm so excited to be here. And one of the important questions that has come up is in the work with HIV, how have we engaged and what is the value and how important has it been to have strong activism and community engagement? HIV is particularly special because we have that group and we're able to move the time from starting a guideline to implementation within less than a year. And it's very interesting to hear how in other departments at WHO, they expect that time from policy development to translation to be up to 10 years, because it's not WHO that's moving it. It's communities, it's ministries of health, it's people who are living with a disease that are moving the policy and holding their governments accountable.
In the project, we also work very close with policymakers and researchers who have been quite an assistance with the developing of the materials, and also they have helped us to ensure that we deliver the right kind of information. They have become part of the family whenever there is a policy issue or there is a research issue that we really don't have much understanding about. There is someone that we can reach out to who can clarify things. Their presence made a huge impact because through them we are able to get information before it reaches other people. Their presence has helped to enhance the trainings that we do for the communities in order for us to be able to deliver information that is accurate and that is scientifically proven.
I guess my earliest engagement with the activist community was actually the Treatment Action Campaign, probably around 2000. And then just watching the community programs, the education programs, I'll never forget this very famous South African rural professor saying to me, it was about 2010 or so, he said the difference between an HIV patient and a diabetic hypertension patient is it goes to the diabetic patient and you'd say, what's wrong with you? And they'd say, I've got high sugar. And you'd say, what else? And say, we've also got what in South Africa we call the high, the combination of hypertension and diabetes. And say, what are you on? And they'd say, white tablets. He said, and the HIV patients would say to me, well, the virus gets through the cell wall like this and then enters the nucleus, and then and it was chalk and cheese. And he was just so impressed at the levels of patient education. And again, I think there's such an incredible lesson there for empowerment of people. If you explain to people why they need to take the tablets, they'll take them. You don't need to be prescriptive and top down and all the rest of it. So that also had a profound impact on me, and something which has turned me into this big advocate for community education and community engagement.
Hello, I'm Professor Ntembu from the Treatment Action Campaign based in Mpumalanga Province. I am a provincial treatment literacy trainer. One of the greatest role that I do. Basically what I do is provide scientific information that is related to HIV, TB, ARVs, and opportunistic infections to the community. So you get this information in a scientific way and you try and summarize it or try and put it into a clear view or to an understanding level for the community. We capacitate them with what's happening around HIV, treatment, treatment optimization. And the best way is that we get this information, then we go visit them through their branches. We create community or branch workshops or branch trainings, and that mostly we use branch educators. So the simplest way is that we go and create an activity that we call a workshop or a training. whereby we have around 15 to 20 participants. We train them from trainer to trainee. And yeah, that's the best how they actually get information.
Sanmonani, my name is Merinyati. I am the provincial trainer for Treatment Action Campaign in the Free State Province. And the highlight of my work is the trainings. We simplify the basic science of HIV into our native languages, because we most of the time work in communities where English is not the language of medium. So yeah, our trainings are not only limited to our branches, but we go as far as training the organization's partners, our stakeholders, key role players in communities, because information is power. So we choose to share that power that we have with possibly everyone.
Molweni, igama lam ndinguMariam Dakana. Namhlanje siza kuthetha nge-TB. Neyona ingunobangela wokufa kwabantu abaninzi kwihlabathi lonke liphela.
Sanibonani, igama Khulelani Wagwala. Isihloko sethu sanamhlanje sizokhuluma nge-mental health.
Avuxeni, mina Daniel Motheula wa kusuka ka TAC, ni tirha tanihi treatment literacy trainer a provinsini ya Limpopo.
Meeting people with different values and norms and cultural beliefs, or sometimes religious beliefs, and their different views or mindsets when it comes to HIV. And then looking and experiencing them, understanding the information that you're bringing to a point where there's some sort of behavioral change that is encouraged through the training sessions means so much to me personally, because I then realize how much a piece of information that I could bring could completely change someone's life and in the long run save other people's lives.
So my name's Dr. Andrew Hill from Liverpool University, and we're going to talk about some of the issues that we have with developing drugs for HIV and how we need to keep it real. We need to make sure we remember that these are individuals taking these drugs, and sometimes we can get lost in the science. In my career working with antiretrovirals, I've found it very valuable to talk to people who have HIV and are living with it. And it gives you a real reality check when you're analyzing a study and you're looking at particular adverse events and you're thinking, these are individuals getting these issues, and we need to really pay attention to them and think about what they find to be a problem and not just what we're objectively looking at in trials. So I think it's very important to keep that link and remember that these treatments, they're not just part of a scientific experiment. They're not a group of people who need to be treated. They're all individuals, and we need to make sure that we study as wide a diversity of people as possible.
The methodology that we use when we're developing our materials is very people-centered. We actually consult with mostly people who are living with HIV, people who are affected by HIV, and people who are working in the field with the communities with regards to delivery of HIV services. We have workshops twice a year where we come up with ideas of what kind of materials, be it leaflets or posters that we would like to develop. And we do a lot of brainstorming around the content. We are always taking thought of what the communities are actually saying, because we have the people who are representing the communities with us. And then there's a lot of back and forth between Treatment Action Campaign and HIV IPAs, just to come up with the materials itself, which means that it's a very long process. We don't just go poof and we have the materials. And once the materials have been developed, also we would have consultation again with the very same group of people that we've had when we started the initial consultation, where they come and we do a field testing to see if this really translates well into the real world. And the participants actually get to have a lot of a say as to what goes into it. And sometimes they might come up with an idea that maybe if we can change a certain phrase or a certain word into something else, because it wouldn't be understandable in the communities that we work with. So a lot of work is done not just by Treatment Action Campaign, but we also work with the people who are infected and who are affected, who are the people who will be actually using the materials and who will be seeing it in their health facilities. We came up with the idea of actually naming the series of the materials that we develop modern art, which is ART, antiretroviral therapy. So you can read it on a bus, you can read it on a taxi, you can read it on a train, and no one will have any idea what is it that you're reading, because there won't be a huge HIV splashed upon it. So the materials have been received very well by the communities, because one, they like the fact that they're very compact. You can like put one into your pocket or into your purse, and the fact that they're very colorful and catchy, and even healthcare workers really are looking forward to actually seeing the materials being distributed in their health facilities. Members from different countries to actually adapt the materials to their own context. Like for an example, Zimbabwe has started producing their own materials, and Malawi has also started doing that. Kenya has started doing that, which is quite wonderful. We encourage everyone to actually like adapt it to the context of their country.
My name is Imelda Mahaka. I work for Pangaea Zimbabwe AIDS Trust, based in Harare, Zimbabwe. I've been involved in treatment optimization work for a few years now as a member of AfroCAB, which represents treatment activists across Africa. A big part of our work includes community engagement in order to bring this important work to communities. And a critical component of this is providing treatment literacy materials. That is how we got to work with iBase and TAC to adapt materials and localize them to the Zimbabwean context. At that time, we'd already looked in Ministry of Health and Childcare to let them know that we were developing these materials, and we needed their guidance as well, so that our message was aligned to the Zimbabwean guidelines for art. Very interesting process again with Ministry of Health as involvement. I think one of the things they really appreciated was the way that the materials were simplified in a way that anyone could understand. Another thing Ministry of Health and Childcare appreciated was how colorful the materials were and the pocket size format. This is something that they felt that anyone could put in their pocket or in their bag and actually read, because it wasn't too much, yet it contained all the messaging that was needed. So this process for me has been really enriching, informative, and I've really learned a lot.
And there are brilliant training programs throughout the continent, and mostly through the work of AfroCAB.
Hi, my name is Kenley Sikwese. I am the Executive Director of the AfroCAB Treatment Access Partnership, usually just referred to as AfroCAB, is an Africa-wide network that focuses on improving treatment access to for people living with HIV across Africa. Currently, we have approximately 18 countries where we are represented, and actively working in at least 14 countries where we have ongoing projects for both HIV, HIV mostly, both diagnostics and treatment. But we also have projects in 3 countries in partnership with the Clinton Health Access Initiative, focusing on advanced HIV disease. Optimal ARVs, improving access to dolutegravir in another 10 countries. And then we're also working in 3 countries on diagnostics. We work very closely with HIV-IBASE as well. HIV-IBASE are not only our fiduciary sponsor, but we also collaborate.
The study that was supposed to deliver the perfect regimen with no side effects, that was going to be dirt cheap in a tiny little tablet, that there's nothing to worry about in terms of resistance, and nothing was supposed to go wrong. And it has been my experience with lots of clinical research that nothing goes as planned. And firstly, we were coasting along, doing really well, battled to get the drugs initially, but finally everyone came on board, from the manufacturers to the donors and everybody else. We were recruiting hand over fist, doing a great job. And then, bang, we get hit with the neural tube defect.
We have been talking about how wonderful dolutegravir is from the beginning, and now we hit with this news, and now we have to go back to the communities to actually explain all about the neural tube defects. So we had several consultations, and we tried by all means to make sure that people actually understand the probability of neural tube defects happening. And there was quite a lot of action happening, including demonstrations during IAS in Amsterdam. And also we tried by all means to include the people who are most likely to be affected, which are women of childbearing potential. It's really not recommended for them to be on dolutegravir unless they are on a reliable and long-acting contraceptive, which is a huge challenge in the African context. So we did quite a lot of consultations with young women or women who are most likely to be affected by this issue, and surprisingly enough, everyone was for dolutegravir.
My name is Jackie Waboy from the Africa Treatment Access Partnerships. The journey for advocating for DTG started when we heard about the caution in May 2018, and from then on it has just been a roller coaster of ups and downs trying to advocate for this drug. I actually had a struggle of even pronouncing the word dolutegravir, but I ended up having to take night classes to learn how to pronounce it, and it caught me as a drug that I knew would change how people adhere to their treatment, because it was a drug that was low in dosage, it was a drug that was easy to tolerate, and it was a drug also that would be able to suppress viral load very fast. And this is what attracted me to the drug and attracted me to be able to advocate for it, because it was better than any other drugs that we were taking at the moment. And I myself had been on treatment for more than 10 years, and I've been having different side effects, to the lipoatrophy that made me lose my hips, to the numbing of the feet so that you're not able to, comfortably relax in the evening. So these were the kind of things that I knew other people were experiencing, most especially women who are the leaders in the community and are the ones who actually partake most of the activities in the household. So after I learned how to pronounce the drug, now we noticed that there's something we needed to do after we heard about the caution, and when dolutegravir was being denied usage amongst women living with HIV of reproductive age. So one of the things we did in Kenya, where I come from, was to mobilize these women, ask them their opinions, tell us their experiences with taking HIV drugs, and also the experiences of what it was now to be on the drug dolutegravir, as they had already been switched. And when we got that feedback, we realized that most women were saying that yes, they know that there is a caution, but after they are taking the drug, they realize that they have lesser side effects and they are still willing to continue taking the drug. So we took that advocacy to a national level. We confronted the Ministry of Health in our country, and we also did a lot of mobilization and advocacy before we attended the International AIDS conference in Amsterdam in 2018. Where there we were able to interrupt the WHO session that was to say that dolutegravir should be, restricted use against women of reproductive age. From there, we were able to attract many policymakers, including the Director General of the WHO. And we had a conversation, and it was realized that women want dolutegravir.
Certainly one of the first persons I spoke with once I heard about this potential data and risk coming out of the SPAMO study in Botswana was I communicated with the membership of our civil society on our guideline development group to talk through what this meant. And I think it was a shock for everyone because there was so much excitement and real need for new regimens and desire to see that the dolutegravir would work. And what that forced groups like WHO and others to do is come up with groups that worked on science together, who we explored what are all the different pros and cons and benefits and risks of using dolutegravir. And in the end, with the support and certainly under the pressure with the civil society in terms of holding us accountable at WHO, we were able to move basic science. We were able to help new studies be set up around the world. And we were able to bring people together to review that science so that we were able to put out recommendations that would, for a period of time, hold on the use of dolutegravir for women of childbearing potential, but that it eventually release and open up and be much more liberal with our recommendations as more science showed that this risk was potentially much lower and much more acceptable. I think the other piece was there was a sense of it was the civil society was holding WHO accountable in many ways and saying, if you make a recommendation, it's only going to affect a small proportion of women, and women want to make their own decisions. Give us the information and let us make our own decisions. And I think WHO in our guidelines have always said that we want our recommendations to be person-centered, that we offer options, that they're not black and white, and that a conversation has to happen, especially in the selection of a regimen or a medicine to be used. And that women, men have to have the ability to make some of those decisions on their own, be very well informed. And clearly this conversation around neural tube defects and dolutegravir showed how important it was that we have strong civil society, that WHO was held accountable, and that we were able over time to improve the kinds of language we used around that recommendation.
Having a treatment literate community is very essential for our advocacy. For an example, if you don't know what a viral load is, how on earth are you going to advocate for viral load testing? We are forever looking for better regimens, looking for tolerable, affordable, and efficacious treatment regimens that people living with HIV can take. And now we have to go back and tell them that, unfortunately, this is what is happening. So that was really frustrating and heartbreaking. But we tried to appease the people by actually giving them information on the neural tube defects and explaining to them, which in a way helped us to gather information about what people's preferences are when it comes to optimal ART.
We've had some real surprises throughout the past few years. I've been working on a drug called dolutegravir that's given with tenofovir alafenamide, and the women who take that drug in South Africa have seen some quite shocking rises in body weight that were simply not detected.
Because of our involvement in the advanced study, they started noticing that a lot of people started gaining weight. So that is still a process that we're working on, just to make people to be aware, which is why it's very important for community to be involved whenever clinical trials are done.
So the WHO guidelines were updated to show that women living with HIV of reproductive age can be given dolutegravir if they ask for it and if they're comfortable using it, as long as they are told the risks and the benefits, and to let the women decide for themselves. So most women living with HIV in Africa are accessing the drug, and it has been known to reduce our viral load very, very fast, and we are having less and less cases of opportunistic infections, and we're having women living with HIV having undetectable viral load. And that's the story.
We've realized the necessity or the need of continuous research when it comes to ARVs. And in continuing the research and the knowledge about ARVs, we then realize how important it is for the Treatment Action Campaign to continue informing people and updating people about different ARVs and what they mean or how they're going to be better than the previous ones. There's a lot of misunderstanding when it comes to, for an example, dolutegravir and women of childbearing age. However, through the information that we've been sharing with including professional nurses and community healthcare workers, there's been a lot of improvement when it comes to the rolling out of dolutegravir to women of childbearing age, because we then brought in the sense of being able or allowing yourself as a young woman to use contraceptive, and we also brought in the idea or the fact of women who might not necessarily be heterosexual who want to use dolutegravir. So through this experience of treatment optimization, I've learned that continuous updates and information giving for as high as a healthcare professional to as low as the general person in the community is very important.
Since we are running a training program where we get to reach out to communities, and in most cases our gatherings are groups of 15 to 20 people, now we had to think as to how are we going to do this.
We know that we can't move around, we can't meet people physically. I mean, there are so many restrictions that are in place, and they are all new to everybody. We are all new to this thing. However, technology plays a huge role, especially in the 21st century. We have apps like Zoom, apps like WhatsApp, apps like Facebook, your Twitter, all these social media apps, they are now playing a huge role in terms of making sure that people receive quality information. We are now conducting Zoom trainings. We are now conducting trainings using our local radio stations. We are now conducting trainings using WhatsApp voice notes. And they are working perfectly, especially with Zoom. I mean, with Zoom, you interact with them, just that the only periods that you're using technology, so you cannot meet them face to face.
We have continued to do our trainings remotely through videos that we share on a weekly basis, through teleconferences that we have with our branch members, and we continue to train staff members also. The training department has made means to ensure that the work continues and the information continues to be shared as wide as possible. So yeah, that is, it's amazing.
Belinda, do the counting for us, please.
2, 1.
Treatment literacy.
Treatment literacy.
Let's